Well, good morning. I'm calling this meeting of the House Early Childhood Finance and Policy Committee to order. I'm State Representative Dave Pinto, the chair of the committee, and welcome to members and members of the public. A reminder, this meeting is being held pursuant to House Rule 10.01, which allows for this kind of virtual hearing. Reminder to folks that are on the Zoom call to stay muted when you're not speaking. And you can use the raise hand feature or indicate to our staff if you're interested in being called upon. And finally, the meeting materials have been emailed to the folks on the Zoom call participating in this hearing, but members of the public, those same materials have been posted to our committee's website, which you can find at the House website in our Early Childhood Committee. And with that, I'm going to call this meeting. We'll do the roll call, and so Ms. Chambers, if you can do that.
Yes. Representative Pinto, Chair.
Present.
Representative Pryor, Vice Chair.
Present.
Representative Franson.
Present.
Representative Bennett.
Present.
Representative Bolden.
Present.
Representative Daniels.
Present.
Representative Davney. Representative Davney. Representative Damon.
Present.
Representative Jurgens.
Present.
Representative Kotiza Watoon.
Present.
Representative Morrison.
Present.
Representative Wasilewicz.
Present.
And Representative Wolgamott.
Present.
Awesome. We are at a quorum.
Thank you, Ms. Chambers. And I'll note, I'm not sure if we could hear Representative Dabney, but he certainly is with us. And so, yep, I can see the thumbs up. So we'll make sure that his attendance is noted in case we weren't able to hear him, but he's certainly with us. And so we have two sets of minutes to get approved here. Hopefully members had a chance to review them. I think I'm going to continue asking our Vice Chair, Representative Pryor, to move the minutes from January 19th, 2021.
Thank you, Mr. Chair. So moved.
Thank you, Representative Pryor. Any additions or corrections, members, or other comments on those minutes? I'm not hearing anything. So then all in favor of approval of January 19th minutes, please say aye.
Aye. Aye.
Any opposed? Okay, with that motion prevails from Representative Pryor, and the January 19th minutes are approved. And then Representative Pryor, again, the January 21st minutes, if you can move approval of them.
Yes, thank you. So moved.
Thank you, Representative Pryor. Any additions or corrections, members, to the January 21st minutes? And again, not hearing anything. So all in favor of approval of those minutes, please say aye.
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 Any opposed? Okay, we have our January 21st minutes approved. Thank you, members. And so with that, we're going to move to our main topic today. I'm just delighted to have us be joined by Dr. Cynthia Osborne from the University of Texas at Austin. Dr. Osborne directs the Prenatal to 3 Policy Impact Center, which came out of the scene relatively recently. I think we're going to hear more from Dr. Osborne about that. I should just note, I became familiar with the center in particular early last year when I attended a National Conference of State Legislatures conference along with the late Senator Jerry Ralph, and I got a chance to go there and got to meet Dr. Osborne and interact with legislators around the country. And the Policy Impact Center is doing really innovative work, as you're going to see. And one of the reasons in particular I wanted to invite Dr. Osborne to join us is that this gives us a chance to do something that we love to do as Minnesotans, which is to compare ourselves to the rest of the country and be really proud of various things about ourselves. And then we notice that there's some places where we may be falling short as well. And so this is a chance for us to have that comparison in this area that could not be more critical, which is the first couple of years. And this is why we're on this committee. And so with that, Dr. Osborne, if you can please identify yourself for the record, introduce yourself, and we'll have a presentation from Dr. Osborne for a bit of time, which I know members will find really helpful. We'll save substantive questions for the end if we can, though, Dr. Osborne, if it's okay with you, if folks have clarifying questions along the way, please indicate that. We can certainly pause Dr. Osborne and get those points clarified, and then we'll hopefully have plenty of time for discussion at the end. So with that, Dr. Osborne, please proceed.
Well, thank you so much, Representative Pinto, for the invitation to share what we're doing with this committee. I'm Cynthia Osborne, professor and associate dean at the University of Texas at Austin. And as Representative Pinto said, I have the pleasure of directing the Prenatal to 3 Policy Impact Center. I'm going to share my screen to show you some slides, but I really do want to be here as a resource for you. So please feel free to ask clarifying questions, and I look forward to the discussion that will follow the brief presentation. Let's see if I can make this happen here. Let's see. Okay. So I wanted to start with a bit about what motivates the work that we're doing at the Policy Impact Center. And I know that your contributions to this committee probably means that you're very aware of some of the science of the developing child. But that science really does guide our work. It defines what the conditions are that children need in order to thrive. And our goal was to identify what the most effective policies at the state level that states could implement that could really bring those conditions to life. At birth, our brains are the only organ that are not fully developed. They are expecting to be wired. They're the supercomputer that's waiting for programming. And really, it's these nurturing relationships and stable, safe, warm, nurturing environments that leads to healthy development, leads to higher levels of self-regulation and executive functioning. But when children are exposed to chronic adversity or lots of instability in their earliest years, this sets their body into constant survival mode, both reducing the development of their prefrontal cortex, or the part of our brain that really leads to that executive functioning, and it also impacts all the other systems of our body and has lifelong consequences that are both costly to the individual and costly to society. It is important to know that regardless of children's earliest experiences, that they are resilient. There is a lot that we can do, and we should never give up on them, but it is very, very difficult to undo and redo some of the wiring that's done early on, and it's quite expensive. And what also motivates us is that children of color are the most likely to face these early adverse experiences and have less access to opportunity to thrive. And so we pay particular attention to how our policies not just improve the well-being of everyone, but also close those gaps and opportunities. The research is also clear that we have to care for our caregivers so that they can care for our kids. We know that parents strive to be these parents that are there providing these safe and stable and nurturing environments for their children. But in order to do that, they need the knowledge and skills and resources that are necessary in order to provide those environments. And it's also important that our childcare providers and others who are interacting with our little ones when they're not with their parents have those similar levels of support. The study that we did recently of childcare providers in Austin and in the state of Washington, we found that nearly 40% are reporting depressive symptoms. Another 40% are reporting food insecurity. And these are the folks who are caring for our kids on a daily basis. And the research is very clear that if we don't put our oxygen mask on first, it's really hard to take care of those around us. The research is also clear that there is no magic bullet. We actually searched for it. What is the most effective thing? Can we do one or two things and knock it out of the park and bring that system of care for our children? And the truth is that it does take a system. It takes broad policies that provide those sorts of basics, income and support to ensure that our basic needs are met, that families can both work and care for their children, that working actually pays. And we also need a set of targeted interventions, a way to identify what the specific needs are of families and children and get children into those sorts of services that's more efficient and ultimately more effective. And this combination is what will make both of them have a higher return on investment over time. And finally, we know that investing early is the best investment that we can make. It has both short-term and long-term benefits. In the short term, we see that by making sure that kids get off to that healthy start, that there's reduced use of special education, of healthcare, emergency care. That we also see over time that these are kids who are more likely to graduate from school, from high school, to graduate from college, to earn more. They have lower rates of behaviors such as crime and drug use. They're all costly to society. And I am not suggesting that if we don't invest in childcare, that all those children will end up in prison, but you can see the trade-offs that we sometimes have to make. That in Minnesota, it's about $15,000 a year for high quality childcare. And it costs approximately $40,000 a year to incarcerate someone. So these trade-offs are important, but the investments that we make early really have lifetime benefits. So the Prenatal to 3 Policy Impact Center entered into this space motivated by all of this, and we are here to contribute 4 resources to the field. I'm going to talk primarily about our state policy roadmap, but given that I'm an academic, we started with the science, we started with the evidence. Like I said, the neuroscience, the developmental science told us what the conditions are that children need, and then we turned to the rigorous research to say, well, what studies have demonstrated that these policies actually impact outcomes during that period? And we created a policy clearinghouse in which we have over 24 policies there that you can see the standards of effectiveness of whether they're need further research or that they are effective. And the most effective policies we've put on our state policy roadmap that I'm going to share with you today. But I want to recognize that there are limits to the evidence base. There are some things that are probably working great and we haven't studied. There are other things that we have studied some, but we need to study more. And so we are committed to trying to continue to learn about what works. And to that end, we have our policy research exchange, in which we're interacting with states on a regular basis to understand what it is that you're doing, what your challenges are, what you'd like to be doing, and how we can provide resources, but that other states can also provide guidance to you in those efforts. So with our state policy roadmap, like I said, it's based on these policy, we established these 8 policy goals that are derived from the science of developing child, making sure that families have access to the services that are available to them, that they're eligible for, that parents are able to work, that they have sufficient resources, that children are born healthy to healthy parents, that parents have the mental and physical health that are necessary to provide those nurturing relationships with their children. When children are not with their parents, that they're in these nurturing, warm and care environments, and that we can identify early on any delays that children are experiencing and ensure that we get them to the resources that they need. So those are our policy goals. And we, again, identified, well, what are the most effective policies that get us to those goals? And we identified 11 different state solutions that actually have a significant and substantial impact on those policy goals, on at least one of them. And we differentiate these between what we call policies and strategies, which is really a distinction without a difference or something like that. But to us, it's important because the policies provide, the research provides clear guidance as to what states can do, what laws they can actually pass to create that impact. Whereas the strategies have been identified to work, the evidence says these are effective. The guidance just isn't as clear yet as to what states should do in order to implement these. So those are, the evidence is as strong, but the way to implement is not as clear. But again, these are this kind of range of these broad-based family and economic supports of making sure that families have access to health insurance, that they have access to the resources that they're eligible for, that they can balance both work and caring for their kid through paid family leave, that a minimum wage of at least $10 and a state's earned income tax credit that really makes work pay, a refundable credit of at least 10%. And with the effective strategies, they range from things such as identifying early what the needs are and connecting families with those specific services, making sure that childcare is affordable and accessible, We identified group prenatal care as a strategy that helps to enhance birth outcomes and to provide better mental health and social support for moms. Our evidence-based home visiting programs that improve parenting outcomes. Early Head Start, that does a combination of making sure that children have access to a high-quality learning environment, but also it's a model for how we can care for the caregivers who are caring for those children. And then our early intervention services that are able to identify those developmental delays and get children into the services that they need. So this combination of strategies and policies are the most effective that states can implement to really improve outcomes. I know that kind of a portrait and landscape with PowerPoint doesn't really match up, so my apologies for how difficult this might be to see, but this is Minnesota's roadmap. This identifies, if in the columns, each of these columns is one of our policy goals, and each of the rows is one of the policies or strategies that are most impactful for affecting that goal. And the check marks indicate where Minnesota has made progress. And ultimately, we want every state to make every checkbox, to check every box. And as you can see, Minnesota really is out in front of a lot of states in terms of both adopting policies and strategies that are really that have evidence that they improve outcomes for infants and toddlers. In our roadmap, I wanted to just give you a little bit of an overview of the type of information that you could get from reviewing our state policy roadmap. And we will make sure that you have a link to it if you don't already. But it's a long report. It's 300 pages or so. And we don't expect, although it is great bedside reading, we don't expect everyone to spend all their time reading every page. But each of those 8 goals has its own profile. And we describe why that's important for this age period, how states are currently meeting these goals, and what the most effective policies and strategies are to impact that goal. For instance, if your goal is to make sure that our households have sufficient resources, these are the 5 policies and 1 strategy that impact that goal. And we provide for you evidence of that impact, taken right from these causal studies. So for instance, paid family leave, access to paid family leave is associated with a $3,400 increase in annual household income. We also demonstrate how a state minimum wage of at least $10 an hour is associated with poverty reduction. So this is the evidence that we often look for to say, well, why would we do this? Does it work? For each of our 11 policies and strategies, we also have a profile so that you can fully understand what it is and why it's important for this age period, the impact that it has, and what we're still trying to learn about it. And we provide a lot of information about how states vary on both the policy adoption, but also implementation of how generous they are, the proportion of families that are being served who are eligible, and so forth. Here's an example of a state earned income tax credit policy profile. This impacts 3 of our policy goals. And again, we demonstrate the type of impact that it can have. So an EITC is associated with boosting mothers' annual wages by nearly 1/3, for instance. So these are just examples of the impact of that policy. And then I'm going to spend the remainder of my time just walking through very briefly Minnesota's state roadmap so that you can see how you stand relative to other states. And each year we will update this roadmap so that you can see the progress that Minnesota has made over time relative to yourselves and relative to other states. And this is just a summary of those 5 policies and 6 strategies of where Minnesota stands. And you can see that you have made substantial progress on many of these and have actually implemented 4 out of 5 of the policies. The only one that you haven't at this point is paid family leave. For each of the policies and strategies in your roadmap, we provide, I call these a vignette, if you will, and there's a lot more information both online in our state data interactives as well as in the roadmap. But this is just a snapshot of where Minnesota stands relative to others on some key indicators about this policy. So the barometer, the kind of red to green, demonstrates where you are relative to other states in terms of adopting and implementing this policy. States only get credit when families actually have access to these policies. So you have obviously expanded Medicaid, which is one of the most effective policies at improving birth outcomes and also financial stability for families with young children. And you can also see that you're one of the states with the lowest number of women of childbearing age who do not have health insurance. Unfortunately, this 47.7 over here, nearly half of women who don't have health insurance is Texas. That's my home state here. But you have fewer than 10% of women without health insurance. Room to improve, but you're certainly near the top. When we look at something like administrative burden, this is the hurdles that families have to go through in order to get access to something that they're eligible for. This is an area, given the state of budgets across the country, that a lot of states are focusing on. They've seen in the wake of COVID that they needed to reduce some, make eligibility or access easier to do things online, for instance. And a lot of states are considering keeping some of these things in place so that more folks who are eligible can actually access this. And you can see in Minnesota here, there's about 13% of families with children who are eligible for SNAP who do not currently receive it. And so that's an area that can be improved upon.
Dr. Osborne, can you go back to that? I actually have a clarification question on that, which is I noticed that we are in the colored row there, line there, we're all the way to the right. So we're in the group with all the other best states. But then there's quite a gap when I look at the number between the 13% that are not receiving SNAP versus 2% from the best state. I'm just wondering if you can comment real briefly on I'm just curious about the difference, since it seems like we're in the same box with all those other states. What's that 2% state doing that we are not?
Yeah, well, that's a really good point. And we're looking for more of those answers and going to, in this next iteration, provide more than just the information about the certification interval. So right now, this is just about whether in your state statute that you allow for require a recertification interval of at least a year. But the research actually shows that it's a combination of policies, making sure that folks can get it online, making it so that there is kind of simplified reporting. And there's also some research about stigma, and that's something I don't understand or know in Minnesota, but I would venture to guess that there are probably some communities or some groups that are less likely to be signing up for this benefit who are eligible for it. And that could be due to lack of communication. It could be due to stigma. It's something I'd love, I'd happy to explore further with you, but I wish there was a 1-to-1 ratio of, if you do this, then everyone will be served. But you point out that that's not always the case.
Thanks very much. And I'll just remind members of the public, it was just a week ago that we received just a very broad-based briefing on SNAP and some of the other programs that are supporting families. So anyway, thanks, please continue.
Great, thank you. So paid family leave, this is an area in which we see across the country a lot of enthusiasm for folks to consider it. It's obviously something that in the wake of COVID at the federal level, paid family leave was extended for families who were struggling to care for their children or loved ones because of COVID. Currently, there are, Massachusetts just went into effect, so now 6 states in which families can actually receive benefits, and there are several other states who have passed this legislation, but have yet to fund it, and so they are waiting for the families to be able to receive it. But this is an area that has a lot of attention across the country. A state minimum wage is of at least $10 an hour is also one of the policies that demonstrate that they have a big impact on outcomes. And it's interesting because it's not just income. This is actually one of the policies that has one of the biggest impacts on improving birth outcomes and reducing disparities in birth outcomes. So this is also associated with reduced neglect among children and kind of a range of benefits beyond just income. And you can see in Minnesota that you actually have one of the lowest level of parents who are working for less than $10 an hour. And some of that can be because they're in tipped positions and so forth. But this is, there's only one state that's at, or DC, who's at $15 an hour. With the state earned income tax credit, this is obviously a benefit that really targets working parents and has one of the largest impacts on well-being, especially for their income, reducing disparities in birth outcomes and so forth. And you are one of the most generous states with a 34% refundable EITC. And you're one of the states that are out in front on making sure that those folks who are eligible for it are actually receiving it. I'm going to, in the interest of time, I'm going to just kind of go through these different strategies very quickly, and I'd love to come back and answer questions. But again, these are the more targeted interventions of things that you can and should do if you want to improve these sorts of policy goals. And we demonstrate the progress that your state has made. We have a lot of information on childcare subsidies. This is an area that states are trying to figure out how to get right. We don't have clear guidance. The federal government says it recommends that we do a market rate survey with at least that's no longer than 2 years old, and that we set the rate that it's 75th percentile of that market rate survey so that families would have access to 75% of all of the market. There's only one state that actually does that. And the evidence isn't clear that the market rate survey is the best approach. So it's something I'd be happy to spend more time on. We have a lot of information about what it is that you are doing. But I wish we had greater guidance on exactly what would be the most effective.
And Dr. Osborne, just if you can go back to that slide, I just want to make sure that there is a correction in the box there that says 2012, the year the most recent survey was used, because of work that passed through this committee and through the legislature last summer, that I believe should say 2018, that the rates are now set based on that most recent survey, though that number does not update. That year does not, so it's going to stay at 2018 unless we act, and then we'll fall out of federal compliance. But I think that since this was produced, that we did do that updating.
That is wonderful to hear, and I appreciate that. And any corrections we want to hear from you, and we will make those corrections and show any progress over time. But I appreciate that. There's a chart in the roadmap that this obviously is has way too many numbers and so forth, but it does demonstrate where your total cost of childcare is relative to other states, as well as what your state contribution is with regard to that reimbursement. This is our base reimbursement rate to have the largest area in your state. This is an average here. And this chart just demonstrates kind of where you are relative to some of the most generous states and where you are relative to some of the least generous states. And so childcare is quite expensive. In Minnesota, it's expensive everywhere, but quite expensive. But you are a state that actually contributes more of what you pay than some other states. Your co-payment rate is actually relatively low, although you do allow for providers to charge the difference of what we call a fee. So some families would have to pay that $330 in addition to the $87 in order to access care. Again, I can come back and discuss this later if you'd like. I'd like to just go to the final slide. So in order to demonstrate your progress toward these policy goals, remember we started with the science of developing child. We said, what are the conditions that children need in order to thrive? And that led us to these 8 policy goals. And then we said, well, what are the most effective policies that impact those goals? We have these 20 outcome measures that demonstrate the progress that you can make by implementing these policies relative to each of these goals. And this is a point in time of where Minnesota is on these sorts of outcomes, and will show changes over time. I have to say that because of COVID, the next data that we have, which will mostly be from 2019, will be somewhat irrelevant. The state of well-being has certainly changed in the wake of COVID, and our data is going to take a bit to catch up to us to let us know. But the trends are probably going to be very similar. And what you see here is when your state is far to the left, you are kind of lower among other states. And when you're further to the right, you're among the best states. And Minnesota has a lot of outcomes in which you are actually looking very strong. But there are some areas in which you could stand to focus on for improvement. And this is just that guide that demonstrates where you are relative to other states on these sorts of outcomes. So, I'm just providing an example for whatever reason, your state is one of the lowest with regard to immunizing kids fully by age 3. But you are one of the highest states in terms of breastfeeding, for instance. So that's the way that you would look at this information. I am going to, I just want to make sure to offer myself as a resource to you going forward. And obviously Representative Pinto knows how to contact me, and we are here to be a resource for you. And so I would love to open up for a discussion or to answer any questions that you might have.
Dr. Osborne, thank you so much. And for members and members of the public, I'd ask Dr. Osborne to keep things relatively compact, so we could make sure plenty of time for discussion, number one, and also just recognizing that in the Zoom platform that can be a real challenge. And so just as I'm going to start calling on folks, I'm just going to note that especially some of those slides towards the end in terms of the strategies, comparing where we're at, if those are things that are appealing to you, we can go back to those. I'll just remind you that the references were to group prenatal care, evidence-based home visiting, early Head Start, early intervention, all just critical topics. But we'll dive into questions, and then if folks want to go back to any of those, they can. I think the first hand up was Representative Pryor, and then we'll work our way through everybody else. So Representative Pryor.
Okay, thank you, Mr. Chair. And certainly there's a lot that I would want to sit and go over and review and think about. Just really appreciate the presentation. I think it's one of the best I've heard in terms of that whole overview. So thank you for being with us this morning. So the one question I have right now, just as a starting point for me, is you're talking about Minnesota has, if I understood it correctly, we have relatively high cost of childcare. And
Yes.
and then relatively low subsidizing public support for that cost. And I guess that's my first question, is to make sure that I understood that correctly.
So let me clarify on that. The cost of care in Minnesota is relatively high, although it is there's several states that have very high cost of childcare. Mm-hmm. And your reimbursement rate, which is the subsidy rate that you provide to families, is actually quite generous relative to other states. It's actually quite a bit of that cost. It's not at the 75th percentile, which is what the recommendation is for states. And now you're basing it on a new market rate survey, which will give us a more accurate understanding of what the cost of care is and where you should set your rate. That it's actually pretty small is the level of copayment, the amount that you require a family to pay based on that total cost of care is actually quite low. However, there's a difference between the subsidy, the amount that the state says we will pay to the provider, we pay this much, the family pays this much. And then there's often a gap between that amount and what the total cost of care is on average. And that difference, some states say the families have to pay that difference. Some states don't allow for families to have to pay. They would say the child care provider has to absorb that difference. This leads to a lot of difficulty because some providers are saying we can't afford to absorb that difference, and other families are saying we can't afford to pay that. And so that means that lower income families have to go to lower cost of care, which is often associated with lower quality. So my point was that the amount that you pay of your reimbursement is actually quite high. The co-payment that you expect the families to pay is quite low, but it's the fee, it's the difference between what the reimbursement is and the total cost of care that can be quite large.
Okay, so what we have
Representative
to,
Pryor.
thank you, Mr. Chair. So we have to focus on this gap that we're leaving.
Dr.
Right.
Osborne.
All right, all right.
Representative Pryor.
Thank you.
All right, thanks, Representative Pryor. Representative Jurgens, you're up next.
Thank you, Mr. Chair. And this Representative Pryor kind of already asked my question, so I'll ask it just a little bit more specific. With the cost of childcare, what are you seeing in other states besides subsidies that might help bring down the cost of childcare for families? Are there tax breaks to the daycare centers, or just is there anything innovative that you see in other states that we should consider taking a look at here in Minnesota?
Dr. Osborne.
Oh, I'm sorry. Thank you. That is a great question, and each state that I've spoken with seems to be grappling with this because, as you're well aware, the difference is quite large between what the actual cost of care is and what would be affordable for the average family. So there are some strategies in which states are they are setting the reimbursement more at the actual cost of care. They're allowing for, it costs more money, but they're allowing for a higher level of reimbursement to the centers based on what it actually costs them to provide care, rather than take the average of the market. So that helps some of the centers that have been lower quality and lower cost to be able to raise that, and they provide more money to the families. There are other states that are working on a shared services sort of model, trying to reduce some of the overhead costs amongst some of the smaller childcare centers. So rather than having to have a different director at every center, they can have an executive director and then kind of a managing person within each of the centers, which can reduce some of the cost. There are states that have, or communities rather, not states, that have done taxes to, part of their sales tax or part of a children's tax zone. I'm sorry, I'm not getting that correct. There's a, Colorado is doing this, where there is a kind of set aside for childcare and childcare expenses to be paid to providers. There are other states that are working toward contracts, which allow, rather than vouchers, which basically allows centers then to better plan for the variation that typically happens with their reimbursement levels. So this way they can staff better, more consistently, and they can therefore recruit at the level that they know that they can staff. So Illinois does some of this contract work. But I'll come back to you, Representative Jurgens, with more information on that if you'd like. But those are some of the examples that I can think of off the top of my head.
That's
Representative Jurgens,
pretty good off the
before
top
I
of
go
your
back-
head, Dr. Osborne. Thank you.
See, Dr. Osborne is extremely knowledgeable, and we'll be eager to get that information back. I want to make sure just to note for folks that that comment Dr. Osborne just made about contracts versus I think you used the term vouchers, in a way that parallels our early learning scholarships pathway 1 versus pathway 2, and folks being familiar with that, the idea that that either the scholarship, early learning scholarship, goes with the child, versus it's something where a provider of whatever kind, a district or otherwise, can plan and as Dr. Osborne was referencing, contracts. So just to folks can understand that pathway 1 versus pathway 2 idea for those scholarships. I also want to note, Representative Jurgens, that we're going to be having, and for others as well, a presentation on the economics of early care and learning on this Thursday, and then I'm hoping as well next Tuesday to really build on some of those points. Representative Bolden, I think that you're up. And Representative Jurgens, looks like you were done, correct? Yeah, I'm kind of seeing you. Representative, okay, all done. Representative Bolden, you're up next.
Thank you, Mr. Chair, and thank you, Dr. Osborne, for that really great presentation and really valuable information. My question, actually I have 2 questions that are related around racial disparities. I'm wondering if you are collecting data or have information that speaks to those racial disparities that we know are a reality here in Minnesota. And in terms of strategies and policies, are there, ones that, affect that, more so than others, or anything different that you would look to outside of those that you have already described to work towards closing that gap? Thank you.
Dr. Osborne.
Well, thank you for that question. And the data that we have at the national level does not always do a good job of helping us to break down race ethnic differences within states. There are some outcome measures in which we can do that, and we do share that. But for a lot of our data, we're not able to, often because of small populations of communities of color in some states. So in Texas, we can get a pretty good look by race ethnicity. But in Wyoming, for instance, we can't. So we're not able to share it for every variable, but I can share with you the ones that we do have. When we do probe and we look at the descriptives and add a bunch of years together, we see the patterns that you would suspect, and on nearly all the outcomes. Birth outcomes are the place where it begins. Children of color are much more likely to be born low birth weight and preterm, higher levels of mortality, both infant and maternal. And those birth outcomes really set the stage for so much else to come. The levels of income between a white and Black and Hispanic are 2 to 3 times. And kind of all of the health outcomes are also better among families who are white and families of color. Not for every single outcome, but the pattern is there. When we look at policies that are the most effective at reducing those disparities, really we try to see what will start at birth. And interestingly, the earned income tax credit and a minimum wage are the most effective at reducing adverse birth outcomes. Our group prenatal care, that does work. It's not quite as effective as we would like. The outcomes are relatively similar for birth outcomes, but the moms feel better. They feel better and more supported. But we see the biggest reductions in adverse birth outcomes from Medicaid, moms having access to Medicaid before they become pregnant, a minimum wage, and earned income tax credit. There are some policies that haven't actually even been evaluated to look at differences by race ethnicity. We're trying to push those data to see if we can find that information. And our next stage of what we're doing is going through each of our policies and saying, here are the state levers that actually enhance equity, and here are some of the decisions that states make that may perpetuate inequality. So I don't have all of the answers for all of the policies yet, but that's our next step in our approach that we're taking to answer precisely the question that you just asked. But it really is about the resources that reduce the pressures on family that allow then for all of the capacity to kind of flourish that families have.
Representative Bolden.
Thank you for that. I appreciate that. And I just think it's important for this group especially to keep in mind as we look at that continuum and seeing, where Minnesota falls in terms of worst state and best state, that we are doing really well in many areas, but that may not be the accurate picture for our BIPOC communities. So thank you.
Thank you, Representative Bolden. And when in fact, I think Dr. Osborne knows the context. I hope that all legislators do, that our state certainly has some of the very worst of those disparities in the country. Before I move on to the next representative, next member, I just want to clarify myself. Dr. Osborne, you talked about the power of the minimum wage increase. For low-income families and for birth outcomes, we sometimes hear an argument made that in fact increasing minimum wages is harmful for low wage workers. And that some would cause some to lose their jobs, et cetera. Can you just talk about, does the evidence take that into account, kind of the full picture for lower wage workers?
Yes, so thank you for that question. And obviously with the introduction at the federal level of a $15 minimum wage, this is a conversation that is taking place even more. So the original research that was done, Carden-Kruger back in the 90s, that looked at an increase in the minimum wage and its impact on employment, it initially was finding that there were negative impacts on employment, that if you increase the wages, that business owners would say, well, we just can't hire as many people, and they're going to scale back. Over time, though, the value of the minimum wage at $7.25 an hour has declined so much relative to prices even, that seems to no longer be the case. Now, the research only is on a minimum wage between $10 and $12 an hour. There hasn't been research much on a $15 an hour minimum wage because there's very few places that have actually put that into place. DC is one, Seattle is one. And so I can't speak to what a $15 an hour minimum wage would be, but a $10 to $12 an hour minimum wage does demonstrate that it has very minimal impacts on employment, and it is that are certainly offset by increases in wages. And the impact on prices is relatively small as well, because like I said, the value of the minimum wage has the real value of the minimum wage has declined so much. If it were set at what it was in 1965, it would be $24 an hour. So we may have had it too high then, but we may be too low now.
That's helpful. Thank you for that clarification. Representative Katiza-Watoon, you're up next.
Thank you, Mr. Chair. And thank you, Dr. Osborne, for being with us today. I think on one of the very last slides that you had showed us, it was kind of like a listing of the different best, worst sliding scale. One that caught my eye, I think it was toward the bottom, and it was one where we were over toward the left side of the chart, was maternal mental health. And I was just curious, what kind of are the parameters for that? I'm 6 months postpartum myself, so it's something that's very applicable to my personal life right now. And obviously, as serving on this committee, it's something that's a professional priority for me too. So I'm curious, is that measured in kind of like the first 12 months postpartum? Is it like, what does that term mean? Is it more early childhood targeted, or is it kind of like lifetime being a mother? This is what mental health looks like for women.
Dr. Osborne.
For that particular measure, it is for women who have a child under the age of 3 who report their own depressive symptoms, but it is, it's not for, it doesn't take into account postpartum depression, which is slightly different than depressive symptoms or depression that is not related to pregnancy. Each are obviously incredibly important, have a bit different of origin and treatments. So this is really moms who are feeling stressors and strains that lead to depression. And if I, when I look at these 20, there's so many to pay attention to, but if I had to pay attention to 3 outcomes and I couldn't measure anything else, I would look at preterm births, because that's where your kids are starting, and that tells you everything about the health of the family before they're born. Obviously, not every preterm birth is an environmental thing, but that is one. I would look at that maternal depression, maternal mental health, moms who feel supported, who feel like they are able to take on this role. And I would look at child poverty, those under age 3, because that's just a bellwether canary for so many other things. And so in the roadmap, we do discuss some of the policies that actually try to impact maternal well-being. And a lot of those, again, go back to reducing some of those financial pressures, making it so that they can balance caring for their child as well as working. And there are therapies and other things that are extremely important for women who face depression, but the prevention side seems to be reducing those environmental pressures that reduce those stressors that improve maternal mental health.
Representative Katiza-Witoon. Any
Thank
follow-up?
you. I appreciate that.
Okay, good. Thank you. Representative Pryor.
Thank you, Mr. Chair. So, I mean, given the opportunity to continue this discussion and ask some more questions, another area that I wanted to talk about or find out more about and get perspective on is in the childcare industry, the childcare providers. Are you looking at the quality of care and states that have, you know, effective systems for supporting quality care and that aspect of it? And then another question related to that too is kind of like, you know, whether or not somebody can afford to work as a childcare provider. I know in Minnesota we have, you know, very low wages for this profession. And then, so is any kind of relative understanding of where we stand and how important that might be to the success of our nurturing our children. So the two related questions. Thank you. Thank you, Mr. Chair.
Dr. Osborne.
Great. So the first question about quality, if I could wave a magic wand, it would be that I would better understand all the elements that improve quality of childcare. And this is where I'm going to say that the academy or academia has really failed the field, if you ask me. We have argued about how to measure quality. We have decided whether we're supposed to link quality to child outcomes or to structural things. And we have tried to look at each little input into childcare and say, does that lead to quality? Does that lead to quality? When most of us understand that it's a combination of elements that will enhance quality. There's no single ratio that you can set or standard that you can set that's going to have this magical and, you know, improvement on quality. And so we are still trying to figure out what the right combination is. Most of the work is focused on 3 and 4-year-olds because that's where most of the children are, and they're larger class sizes. You can do more experimenting. There aren't a lot of new moms or dads who are interested in having their child randomly assigned to a room of 2 to 1 with a person or a 4 to 1. So there's a lot that we don't know. What we do know, though, is there are 3 things that seem to be crucial for enhancing quality. And the first is that what's going on in the classroom focuses on those nurturing relationships between the caregiver and the child. And in order to facilitate that, you need to make sure that there aren't 6 infants to 1 adult. That is just common sense for any of us who have ever taken care of 1 child, let alone try to take care of more than 1 at a time. That is a lot. So there are some of those structural things that make sense. You need to make sure that the caregiver understands how to interact with that child and has the resources and skills to do that. Secondly, you have to make sure that the caregiver has the support that they need in order to kind of engage in those nurturing relationships. It goes back to one of the slides that I presented early on, that we do have to make sure that our caregivers are well cared for. And so some folks are focusing on wages. That is important. We did a study to see what the impact of an increase in minimum wage on childcare worker health might be. Again, the impact was pretty small. The increase in wages was pretty small, and so therefore the impact was pretty small. But there are other things that childcare workers need in addition to wages. They need to make sure that when they're sick, that they don't have to come into work, that they have someone to back them up while they're there, that they are respected, that they are seen as the professionals that we expect them to be. So there is a lot of work on trying to find that optimal wage, but and whether it's scholarships or payments and so forth, not clear yet exactly what that is. The third element, so we have the nurturing relationships with the child, focus on that, make sure the caregivers are well cared for. And then third is to make sure that childcare is seen as part of a larger continuum of care, that the child care providers are able to connect the family with the community resources that they need. They're able to interact with, in Mississippi, for instance, they're starting to work with pediatricians to make it so that the well child visits are giving these developmental screenings and socioemotional screenings before the kids are coming to childcare. They're trying to kind of create that partnership. It is making it so the childcare center is really connected to the rest of the community and sees it as a support for families. And to be honest, that's what Early Head Start does. That has all of those elements, and that's why it is on the list as well. But it's those sorts of key elements that seem to be important.
Representative Pryor, any follow-up? Looks like not. Before I move on to the next member, I had a question relating to what we're just discussing. Are there states that have made substantial investments in that workforce, the early care and learning workforce? I'm recognizing that, and again, members, we're going to hear more about this in the next week or so, but just how low paid that workforce is, et cetera. I'm just wondering if there have been investments that have been made, and are there any preconditions or policies that would support that investment?
So that's a great question that I don't have all the answers to. There have been a lot of changes in the wake of COVID, and it's not clear how much of that is going to be maintained after COVID. So some have basically tried to pay emergency wages to get folks to be able to come in and continue care. I can say that Seattle did increase its minimum wage to $15 an hour, which had a big impact on childcare workers because their average wage is somewhere around $10 to $12 an hour, depending on the location. And the research is still out on that, but there are some early reports demonstrate that there, without additional funds for childcare providers, that increase in wages through a minimum wage has put pressure on the childcare centers themselves. And so if we just increase the wages through a minimum wage or something like that, without increasing the reimbursement to childcare centers, that's probably going to put a big strain on childcare centers because nearly all of their costs are wages. There are other states such as Louisiana that has done more on the scholarship realm instead of paying particular increase in wages. They are incentivizing folks to go back and get higher levels of training and education, and they will can pay scholarships for that or kind of subsidize folks reward folks for doing that. And again, I can share with you some other examples. I don't get it all wrong on the call here, but that is definitely an area in which a lot of states are trying to explore how to both professionalize this workforce, both increasing its expectations for qualifications and making sure that they're compensated appropriately.
Yes, we recognize how critical that work is. One hopes that our society values it more. And I'll note too, and again, we're going to hear more about this, that it's a workforce that's disproportionately women and disproportionately women of color. And that's doing absolutely critical work in our society. And so important to support it. So somebody who's done a lot of work in supporting our childcare workforce, Representative Waslowick, I'll call on you next, please.
Thank you, Mr. Chair. Dr. Osborne, I'm wondering if you can talk a little bit about, you mentioned sort of the three things that have shown to be pretty effective at reducing disparities, and they're things that Minnesota is doing pretty well compared to other states. I'm wondering if you can talk about, the things that Minnesota hasn't done or the things that were not, which of those policies or strategies would be most impactful to maybe reducing disparities, but also just improving things in general for childcare and early learning in our state.
We're having a little bit of trouble with the sound for Representative Waslow, but I think we caught all that. Dr. Osborne, did you? I'll call on you, and if you have clarification questions, please.
Great, thank you. I do want to just clarify if you are talking about for childcare in particular, or if you're talking about kind of early childhood at writ large.
Representative Waslow.
Just early childhood writ large, I think.
Yeah.
Dr. Osborne.
So I'm not going to pretend to be the expert in Minnesota. You obviously know much better about what you're doing, and I would love to hear more about what it is. But the state is an example of how having these policies in place is a necessary but perhaps not sufficient condition, meaning that we do have to pay attention to being intentional about trying to reach out to the groups who have struggled and been left behind. And that comes from really being able to analyze the state level data, which I haven't been able to do. And I'd be happy to work with you, or perhaps you do with some of your university partners, maybe at the Humphrey School, for instance, which is a wonderful institution. But to really look at that information and where the disparities are, and if they are just in these certain communities, if it is geographical, if it is kind of across the state, because that's where you can start to think about kind of implementation versus just policy adoption. I'm just going to quickly give you an example of how California had to deal with this. They had one of the highest rates of maternal mortality across the country, and they were the first to pull together this perinatal learning collaborative, if you will. Really tried to focus in on and look at data and think about how can we reduce maternal mortality. And they went to work, and they did. They made checklists, they had toolkits, and maternal mortality declined quite a bit, by half within 3 years. But the gaps between Black and white mothers did not. And it was because they had all the checklists, but they didn't think about the real experience of families of color, of whether doctors were listening to Black women in the same way that they were listening to white women. And that once they have begun to pay attention and be more intentional in some of these efforts, then they can start to see these closing of the gaps. So the policy itself will help, but I do believe that looking at your data, really seeing where these discrepancies are, looking at the implementation factors associated with that's probably where the key lies.
Representative Waslow, any follow-up? Doesn't look like it. Okay. Representative Bennett.
Thank you, Mr. Chair. So I have a question because this is kind of perplexing to me. So we know that Minnesota on average has higher costs or higher rates than other states. We also know that Minnesota has lower pay for the workers. And we know that the profit margin for childcare centers is pretty thin. So here's what's perplexing to me. If parents are paying a lot more for childcare and workers are getting a lot less and the margins are thin, where is the excess money going? What's it going into?
And we'll be addressing some of this, Representative Bennett, in the next, as I say, in our hearing, in the next couple of hearings. But please, Dr. Osborne, if you can sort of provide your cut on that, because it's an absolutely critical question in my mind, Representative Bennett. So, Dr. Osborne, please.
Well, I will leave it to the experts who are going to be coming in the future to provide you with more detail. But what I have seen across states is that we're not exactly sure, but there are several childcare centers and providers that have pretty high levels of overhead because they'll have one director for 5 classes, for instance, instead of one director for 25 classes or what have you. That I don't know the average size of your centers, but I bet in some of the more rural areas of the state that the size is relatively small. And so then the cost of overhead becomes higher. That is where folks have started to try to look, is to try to break down where it is versus the wages of the childcare providers and then the additional supports that the center is providing. I'm not here to suggest that centers don't need administration and other sorts of supports, but I think that there are folks who, the experts in this field, are trying to figure out what that right balance might look like, how some shared services sorts of models might help to reduce that cost, and maintain high quality. So I don't know the answer to your question, but that's probably where the experts are looking.
And Representative Bennett, and again, I'd really encourage you over this next couple of hearings that we have, please dive into that question. I should see if you have a follow-up question for Dr. Osborne or.
No, thank you, Mr. Chair.
Yeah, thank you. And I guess I maybe can't resist noting, Representative Bennett, that if you think about, I know you taught in the K-12 schools, and just if you consider not just in public school systems, but even in religious schools, nonprofits, I'm not aware of any system, or even around the world, where there's a for-profit schooling system that really works. There's always some kind of outside support that's coming in at the K-12 area. So then you imagine 0 to 5, the ratios are much lower. You can't have 30 infants in a classroom. So I guess my answer to your question, but again, please question the experts in our next couple of hearings, is the numbers just don't add up. It's not that there's excess money. It's that the cost of providing, certainly the cost of providing high quality early care and learning exceeds what parents of young kids who are in the worst position in their lives to pay for that could afford to be able to pay for. Just as if you imagine if we had absolutely no outside support for K-12 schooling, and imagine the parents of the kids that you were teaching had to pay for every bit of it themselves, things would look very, very different. But again, let's, over these next couple of hearings, let's dive into that, and please ask questions of the folks presenting to us, and because it's just a critical question. And thank you for it. Dr. Osborne, I wonder if you could go back in your presentation to the slide where you make the comparison. I guess, let me see if I can see this. The one where you talk about the summary of policies and strategies implemented in Minnesota. I just wanted to, as we're bringing things to a close here, members certainly feel free to raise your hand with other questions, but otherwise, yeah, right on this one. And so it's notable to me. So I guess I just wanted to make sure we won't dive into each of those strategies, though certainly members should ask questions if they have them. But I just kind of want to make sure that we're fixed in our minds that there are multiple strategies on the right side to pursue. And you said, Dr. Osborne, those strategies they all have evidence behind them, but there may not be precise evidence about exactly how to do it, but they all have evidence. And there's a number of things to pursue, but the one that really jumps out is support for early care and learning and childcare. And then on the left side, the policies, the one that is the real gap is paid leave. Can you just talk about the opportunities that you see for our state, kind of stepping back a little bit and looking at your 11 policies and strategies, kind of how we should be thinking about this using what you've gathered?
Yeah, and I think that there are places in which you are already making progress in things like the comprehensive screening referrals. I actually think that I think that you actually do have a Family Connect site, and we're trying to kind of suss that out and make that confirm that. But that is an area that you can build on. I would say when you see an orange, it's an opportunity to build on that area. You don't have to start from scratch. I'm just going to scroll through to the group prenatal care here. Oh, I'm sorry.
And I think it's fine. Yeah, if you want to have comments based on those, yeah, please.
With the group prenatal care, I'm just demonstrating that you already provide grant funding. I wanted to see what it was that I can remember exactly what Minnesota did, but you provide grant funding for this. But there are other states that have started to use enhanced Medicaid reimbursements for group prenatal care. They have written it in for, I don't know, I'm sorry, I don't know if you have managed care plans here, but they have written into some of their alternative payment plans, or they have provided guidance that this is something that they would expect to be in those bundles to try to improve health outcomes, are available on a volunteer basis. So there are small changes that could be made to make this more institutionalized and therefore provide it to more women across the state. Same with your childcare subsidies. The small change that you made in terms of just making sure that your reimbursement rates are set at a more recent market rate survey, that's a step in the right direction. And then we have tools that we can help you with, or the folks who are coming, to really see, is that market rate a good proxy for what the cost of actual childcare is? And would there be any alternative method that you would want to use to actually set those rates? For something that you're starting from scratch, like a paid family leave, that's where states, and again, my apologies for not having enough information here, but there are different states' models. A state like Oregon had to create a whole new agency from scratch, and it basically, the state gave that agency a loan for 3 years and said, okay, now you got to set yourself up. You start to collect this tax, if you will, from families that will go toward paid family leave. Once we collect on that for a couple of years, then we start to pay out benefits, and we're able to pay that money back to the state. Whereas a state like Rhode Island or California tapped into its temporary disability or unemployment insurance, kind of a state already infrastructure. And so states have tried to figure out which approach to go. Almost always it is the employees or the whole public who are paying for this. There's only one state that has employers making any substantial contribution. And that, so the funding mechanism really is the key there of making those decisions. But it's a much bigger lift than just kind of changing some of the small P policies or regulations that would allow families greater access to some of the programs that you already have in place and could just enhance.
Could you, Dr. Osborne, could you go back a few slides? I'm sorry.
Okay.
I just want to the childcare subsidies in Minnesota slide, and I just wanted to, as long as we have your national expertise here, going back a couple more back to the childcare subsidies in Minnesota. There we go. And just, I guess I'll just note for members and want to get comment from you, Dr. Osborne. That red box points out that the federal standard is the 75th percentile of the market rate survey. So there's a survey for members that is done of providers, and you go down, down 25 slots if it was 100, if that makes sense, down to 75th percentile. That's what the federal government says we should be setting our rates at, which makes sense. It's, sort of that portion of the market. We're down to the 25th percentile. And when I actually was at the conference with you, Dr. Osborne, that I referenced from about a year ago with the late Senator Ralph, and I mentioned to some of the other legislators that our state was the 25th percentile. Their jaws just about hit the floor that our rates are so low for providers. And I noticed we're down in that, the farthest left box. I mean, any comment you have in terms of how that kind of rate of the 25th percentile compares to other states? Is it in fact the case that just in terms of the rates alone, we're pretty close to rock bottom there? I mean, any comments you can make about that comparing to other states?
So this is where you compare to other states, and so you are not rock bottom. Just there. I'm in Texas, and we always have Florida and Mississippi. And sorry, no, you're not rock bottom. There are states that pay quite a bit less. The question is, and I'm going to here you can see for each of these links of the bar is what we consider the total cost of care based on the market rate survey, the most recent one that they have at their 75th percentile, that this is what it would be if that families need to pay. And then what you pay is this darker blue bar here, the 1306, and that you expect families to pay a relatively modest amount of anything that's left there. I'm not exactly sure how your rates are set, and it could be that the reason that you are at the 25th percentile is because you are setting it at such an old market rate, and that could be the reason that number is coming out. I'd love to just make sure I have all of the information that you have there as well. But the things that I pay attention to is of the total cost of care, the whole length of this bar, how much are we expecting families to pay as compared to what the state is paying? And this is the expectation of a family who is, at 150% of the poverty level, a family of 3, and what they would be expected to pay every month. And according to my read of this, I think that you guys are actually doing a pretty good job on the co-payment. Like I mentioned before, it's the fee that that you have relatively high levels of expectations for families to contribute relative to the total cost of care.
And Dr. Osborne, practically, if you can go back to that slide, practically speaking, what's the difference, or this one, what's the difference for a family between that co-payment versus the additional fee? I mean, I guess I would assume the family's responsible for both of those.
They are, yes. So
Okay.
the family's responsible for, in this case, if they want to be, average cost of care, which would be $1,700 a month that they would have to pay for that child care. They would have to come up with $417 of it, and the state would pay nearly $1,400 of it. So that's how that would be broken out.
So if I'm reading that correctly, then if you look at the cost of the family, which is what the family really is concerned with, we've got a family at 150% of poverty that is responsible for, that 417 is, if I'm reading correctly, is kind of a lot compared to those other states.
Yes, right. So that is true, that if, so in the DC area, for instance, their cost is slightly higher than yours. What the state pays is the $1,600 a month. That's the base reimbursement rate. They expect the family to pay the $59 a month of a copay, and they don't allow the provider to charge that difference. And so a family is only going to pay $59 a month. But in Minnesota, that same family is going to pay $417 a month in order to get that care. Okay. Or they would have to go to a much lower cost of care, a place that will charge much less, which will probably be lower in quality, and they then would just have to pay the $87.
Okay, that's helpful. And so, yeah, so that full 417 if they're going to have high quality care. Okay, thank you. It looks like we have a question from Representative Pryor, and then we'll wrap things up. Representative Pryor.
And thank you, Mr. Chair. And on that same slide, just to make sure that we understand it, or that I understand it. It's morning still, so sometimes
I
know. Is there a state? I mean, 417 is what we're asking families to pay, given our high costs of childcare, because we're in a high income state, which I think is one of the reasons why we have a high cost of childcare, because things just cost more in general in Minnesota. Is there a state that's higher than us for that cost, that final cost to the family?
Yes. There is. There are several states that are higher than you. So, for instance, my state of Texas is a good example where the cost of care is much less. It's $884 a month. But of that, the state really only pays about half, $457. And then the expectation is that the family would pay $270 as a copay. And if they then they would have to pay this additional 157 in order to access that average cost of care. So if you look at the dark blue bars, kind of the navy color, that's the copay. That's the amount that families, if they receive a subsidy, have to pay regardless of anything else. And when you guys look at yourselves relative to other states in that, you're actually doing a pretty good job. You have a pretty small navy bar. It's this additional fee that a lot of folks don't take into consideration, that families, if they want to access kind of the average care, they're going to have to pay out of pocket in order to do that. And so the two legislation pieces that go along with that is you set the co-payment rate, and you've actually set a relatively small, low level of co-payment rate, which is a good thing from a family's perspective. But you also can determine whether you allow for centers to reap the fee, the difference between what the state and the family will pay and what they're going to charge. And that's going to either be more money out of families' pockets into the providers, or it's going to force families with lower levels of income into the kind of tail end of the market, and only kind of get kind of lower quality care. Mm-hmm. So you can compare yourself on this final column, which is what the total cost of the family would be with both the copay and the fee, or you can compare yourself on the navy column, which is the amount that families they must pay in order to get a subsidy, period. And you can see that in Arkansas, for instance, they have both a low overall cost of care and a very low subsidy level as well. So families just have to come up with $31 a month in order to get childcare, to get a childcare subsidy in Arkansas.
Representative Pryor, do you have a follow-up on that?
I guess just that comment, which is now it makes sense when we kept hearing from that we continue to hear from families, they can't find a center that will they can't find care that will take them. So it's great to say, yep, you only have to pay this much, but then there's nobody that's willing to take basically that payment that you're able to offer them, because they don't have spaces for that, so it's it does bring clarity to what our situation is in Minnesota. So thank you, Mr. Chair. Thank you, Ms. Osborne.
Thank you, Representative Pryor. That's a helpful question, because it seems like from that answer from that discussion that actually for a low-income family to receive average care, they actually have to pay more in Minnesota than in Texas, because it's $417 in Minnesota and $407 in Texas. Anyway, and that's for average care based on this chart. Well, this has been extremely helpful, Dr. Osborne. Thank you so much. I want to emphasize to members of the public that our focus as a committee, I think in coming weeks, will be a lot focused on these issues of early care and learning outside the home. But what I really take from a lot of your work, Dr. Osborne, is how important those family supports are, and some of the other issues. It was important to me for our committee to start this first couple of weeks looking a lot at issues that are not necessarily about outside care and learning, but about all the other things we've been talking about. And this has been just extremely helpful. And thank you for your offer, Dr. Osborne, to provide resources to us and follow up as well. So thank you so much. We really appreciate it, you being with us. And members, please be in touch with the center. I found it to be really responsive. So thank you so much again, Dr. Osborne. Appreciate it.
Well, thank you for the opportunity. And again, please reach out for any questions, and we'll follow up with the information that we promised. Thank you again, and have a great rest of your day.
Thanks so much. Thank you. And members, just our final item is just that a set of rules and procedures for the committee were included in the virtual packet that was sent to members, also posted online. And so I hope that folks have had a chance to take a look at them. If there are questions, please let me know about that. I think they should be pretty clearly. I've received some comments that they seem to be pretty clearly written, which is helpful. I do want to note that there is a deadline for submitting amendments, and so you'll want to make note of that. But if members have questions at all about those rules and procedures, please speak up. and let me know, and otherwise we'll be using them going forward. Maybe I'll just pause and just see if there are any questions about them. Obviously, folks can ask other times as well. And I'm not seeing that. And so then members, on Thursday, we're going to be hearing from Professor Dr. Aaron Sojourner of the University of Minnesota talking about the economics of early care and learning, which I think will be really nice follow-up to the conversation Representative Bennett started and we had with Dr. Osborne. And so with that, I don't see any other questions or anything else. And so with that, the meeting is adjourned. Thank you so much to members and members of the public for being with us. See you on Thursday.